Hi, and welcome to the show, where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today on the show, we have Maria Sheikh. She's an obstetric anesthesiologist, and she wrote the Kevin MD article, Giving Birth During the COVID-19 Pandemic, an obstetric anesthesiologist's perspective. Maria, welcome to the show.
Thank you, Kevin.
So we're going to get into your article in a little bit, but I was wondering if you could share your story with me and tell me a little about your journey to where you are now.
Sure. So I am a third generation physician. My mother is an internist just for practicing, and my grandmother was a gynecologist practicing in Pakistan. So medicine kind of runs in the family. We moved to the United States in 1996, and I kind of followed in my mom's footsteps in medicine. Always had a passion for global health, public health, and especially maternal health, since we've got quite a bit of disparities here in the United States. So I chose to go into the obstetric anesthesiology path because we get to be patient advocates. You know, a lot of people think anesthesiologists are just putting patients to sleep, but our subspecialty is unique that our patients are awake. They remember us, and we get to spend quite a bit of time with them before delivery and do delivery planning, especially for the high-risk patients, the ones that have cardiac disease or other complicated conditions. So that's kind of how I got here, and I'm finishing my fellowship in 2 months, and I'll be heading over to New York City to take my first job as an obstetric anesthesiologist.
Excellent, and congratulations. So let's look at your Kevin MD article, Giving Birth During the COVID-19 Pandemic. Can you share the story behind that article and maybe share some of your experiences as an obstetric anesthesiologist during the pandemic?
Absolutely. So I've always been writing since I was a teenager, but really started writing for the public only a few years ago as mostly a way to kind of cope with what was happening, you know, in residency, and now especially the stresses of the COVID-19 pandemic. And right when we had announced the shelter in place and social distancing, it was just a very unprecedented time for everyone. And my colleagues in other fields were making plans to postpone elective surgeries, kind of have surge teams available for backup in case we all needed to go to the ICU. But the truth is, the show kind of just went on in labor and delivery. You know, babies keep coming during a pandemic, and we really were not being assigned to any other ICU teams or backup teams because we were our own backup. As fellows, we were the backup for our resident physicians, and we were essentially backup for our attending physicians if something really bad happened. So I remember talking to a patient, and she couldn't have her husband with her at that time because there was no childcare. So we allow one partner. So she was by herself, and she was putting a smile on for us, and it was just I could just the fear and the nervousness and just the overall sense of apprehension. Everything was just visible, and we have to be strong for them. So we have to say whatever we can to make them feel better because, in OB, we don't really give them a lot of anxiolytics or anything. It's just mostly you're awake and then you get a labor epidural. So I think just navigating this new path with our patients was a very unique experience. To have to give birth at this time, you're thinking, is this the time to have a child? And then I won't have childcare. You might not have help from the family. And emergencies happen all the time in labor and delivery. So we can't really slow down and say, oh, hold on, I'm going to take 10 minutes to put on my PPE because, well, we have to protect ourselves, but we're on the clock. If there's a fetal deceleration, we're not just thinking about ourselves or the patient, we're thinking about the patient, the baby, and now ourselves. So it was this like third patient concept, which was very, very, caused a lot of mental anguish and stress.
So we often read about the end-of-life situations during the pandemic, but you're absolutely right. Labor and delivery never stops during the pandemic. So what are some of the things that you did specifically to help comfort some of the women who were in labor?
I assured them, if they were not COVID positive, but, they were, at that time, we were only testing people who were symptomatic or a real reason to be tested, and then we were incorporating universal testing, which improved the anxiety of the whole situation for most of us. But to comfort them, I would let them know that, even if they can't have more of their family members, we are here for them, and we're sharing in their fear and their grief about we're all going through a collective grief that we haven't experienced something like this before, that we're all in the same boat here. And whatever we can do to make them feel better, if they want us to sit with them a little bit longer, that's also possible. And just kind of let them know that we're all in this together and that they are not alone.
So you wrote the article back in the beginning of April, and that was at the height of the pandemic. Can you share some of the challenges that you faced and how have those challenges evolved, because we're filming this now the first week of June?
I would say the biggest challenge for me was it's the time constraints, because we had several patients who, like, in labor and delivery, the most nightmare situation is if a patient just comes in through the door and then you don't have fetal heart tones. The patient doesn't even have an IV. You're not even ready for anything. So, as anesthesiologists, we get the call from the obstetrician saying, all right, hey, we got to rush back to the OR. So in a normal situation, non-COVID days, we would be getting an IV, or we'll be taking the patient to the OR. We have maybe our anesthesia resident physician or the attending is getting an IV while we are pre-oxygenating the patient to go to sleep under general anesthesia, and we're doing a crash stat C-section. So that's already an extremely stressful situation, and especially if you have a terminal fetal bradycardia, or if you have no heart tones, we need to get that baby out as soon as possible. Now you add a symptomatic person under investigation in that same situation. They're febrile, they maybe had recent sick contacts. So getting on all of your PPE, getting on your N95 appropriately, if you're using a respirator like a CAPR or PAPR, is just unrealistic in that situation. So I thought it was almost darkly amusing that, we practiced all this and we trained, but it's not practical in a obstetric setting. Get our N95 on, get everything on, and be in the room and ready to go. And we are doing the most dangerous procedure. We're doing an aerosolizing procedure in an uncontrolled setting. So kind of overcoming that stress. And we had a couple of real life drills like that where we had to move quickly, and we were in our pee and we were head to toe just sweating, and you're yelling also because people can't hear you. It was just a very, very challenging time. And also with the patients, just trying to explain to them what was happening in that situation. Things are moving quickly, and nobody wants to be asleep for their C-section. Most people don't. They want to be awake and be there for the baby. So trying to do all those things in a rapid manner, but also earning the trust of the patient, a patient who's never met you before, and as to why you're putting a mask on her face, why you're attacking her from all sides. So we're just trying to do all of those things very rapidly. On top of it, being in full PPE, that was the roughest of all. For people to realize that things were very tough for us.
And how's the situation with the PPE now compared to back in early April?
The situation is much better because the universal testing, which we started that in April, I believe. And we now, if somebody is positive or negative, and, of course there's sensitivities and specificities, but if somebody tested positive, you can be pretty sure that they're positive. But if they tested negative and if they're still symptomatic, we had a much better idea of who is positive, where to use the PPE and where to conserve it, rather than just blindly, we didn't test this person because they didn't meet the criteria. And at the time, the criteria has been evolving. So being a lot more sure about where the COVID patients might be.
So let's take a step back. And I was wondering if you could share with my audience something that you're passionate about or something that you've been curious about over the last few months.
So I'm quite curious, and most of our multidisciplinary research efforts with the OB team also is to study why certain populations are being disproportionately affected by COVID-19, especially in our obstetric population. We're seeing very asymptomatic positive in the slightly lower socioeconomic status. and people of color. And once again, they're disproportionately affected by disease, and that's an area that we're studying right now. And as more research comes out across the world, I like to compare that with other data to see, what other people are seeing across the world.
And my final question, what's your take-home message for the Kevin MD audience?
My take-home message is that being a doctor is a very, very challenging experience, from the pre-medical training to medical training, and even as you graduate on into your fellowship and also into your attending physician, which is the transition I'm in right now. Is that you need to find something that is uniquely yours, that really makes you feel like you're doing something bigger than yourself. For me, that's writing. It's telling people's stories, also kind of like how you're doing here. And really, really, especially in this political climate and the unrest that we're going through, really finding something that centers you, and also really listening to other people. It's difficult to validate someone else's experience if you haven't experienced it yourself, but really listening to other people and knowing that other people think differently than you. And that is the step that we have to take if we want to make any change in our society. So we should change the world where we are before we go out to third world countries that need changing. We have a lot of work to do here. So find something that centers yourself, and really, really just learn to listen a little bit more, and that'll, I think, take you really far in medicine.
Well, thank you for sharing those wise words. On the show today, we have Maria Sheikh. She wrote the Kevin MD article, Giving Birth During the COVID-19 Pandemic, and Obstetric Anesthesiologist Perspective. You could find her on the Epidural Doc at epiduraldoc.com. And Maria, thank you so much for being on the show.
Thank you so much, Kevin.